About myocardial infarction. Necrosis of the myocardial cells is what an infarction is. So ischemia is a lack of oxygen to the cells. But when we're talking about infarct, that means there's no oxygen and the cells are dying. And I probably should redo these figures because I'm sure there's a lot more. 785,000 people annually get an MI. And of those, almost half have a subsequent infarct. So these infarcts usually happen on patients that have some kind of history, CAD. It might not be diagnosed, but they do have heart disease. Okay, so the infarct, what happens is there's a prolonged ischemia that lasts between 20 to 45 minutes, and it leads to damage of the heart. Other things that can happen: cellular acidosis, electrolyte imbalances, hormones released by damaged cells can cause to other dysrhythmias and decreased contractility, cardiac output, and BP and tissue perfusion. Okay, so how we describe an MI is where the area of damage is, okay, determined by the coronary arteries supplying. So we talked about that in the last video slash PowerPoint. We have the anterior and septal, we have the lateral, and we have the right ventricle inferior and posterior, so the RCA. So by being able to identify where the infarct is, helps us predict any kind of complications that they might have. Okay, so what we usually see with an infarct is you see ST depression, which is caused by the decrease of oxygenation to the cells, and then it goes into an ST elevation. And that's why we talk about an ST elevated MI. An ST elevated MI, or a STEMI, is the infarct. Okay, that means that cells are dying. Whenever we say a non-STEMI, that means that it's a non-ST elevated MI. So yeah, there was an infarct, and maybe there was a little blood clot that got in the arteries, or maybe a little plaque that caused, an infarct. But then for whatever reason, maybe the blood supply pushed it through, it resolved itself. So when we talk about a non-STEMI, it's still an MI, a heart attack as you will, okay? But it's not as serious because cells haven't died, okay? So the troponins so let's go back. For when we're talking about an MI, we're talking about ST elevation, we're talking about troponins being elevated, and remember those troponins are every 6 hours, and a CKMB being elevated. So that is muscle that's dead or damaged. Let's say damaged. That will be also elevated. With a non-STEMI, okay, you will have your elevated troponins. Okay, they're probably not going to be as high as whenever you're talking about STEMI. The CKMB, a little bit maybe an elevation, not much, but your ST elevation, there won't be an ST elevation. Okay, what you'll see with a STEMI is a tombstone appearance, and we'll show that in the next slide. Now, when you're looking at a 12-lead EKG, each lead deviates what part of the heart, okay? So like the 2, 3, and AV5, and you can see 2, 3 is the anterior part of the heart. The V1, V2 is the septal, okay? The V3 and V4 is the anterior, so when you're talking about the anterior, that's a lot of the ventricle, right? The left ventricle, didn't be exact. The V5 and D6 is the lateral, and then the 1 and AVL is the high lateral, and that's up there, okay? So if we sit there and we see that maybe leads 3 and 2 and 4 have an ST elevation, that's an acute MI, and we got to do something. It's generally 3 leads or more that constitutes a acute MI. So let's at our tombstones. Okay, if you can see, tombstones. Okay, so you have your QRS, and see how that T, I don't know, it's not your T, but whenever your QRS comes down, it doesn't come down to the starting point of the line. It stays elevated. So that's considered ST elevation. Now, we're not talking about, oh my gosh, it's blaring out you. But when you come down to V2, look at those tombstones. You have your P, QRS, and then that ST segment doesn't even come close. It goes up. Okay, and kind of looks like a tombstone. Okay, use your imagination. It does look like a tombstone. Kind of reminds me of those ghosts from Pac-Man, but that's beside the point. You guys probably don't even know what Pac-Man is. Okay, well, maybe some of you do. And you see down here, V1, look at those. It never comes down. Pretty sure I could find a better one from, this one's from 1994. Holy moly. But you see how that elevation is. Okay, and then you have more tombstones up here. So, acute STEMI, right? It says ST elevated MI. Okay, so here's all the complications, dysrhythmias and heart failures. If you notice, they're asterisked. There's a reason why they're asterisked. They're the two most common problems with the person that just had an MI. Okay, so with dysrhythmias, PVCs, VFib, VTAC, AFib, A-flutter, and blocks. Your atrial blocks. Well, you can have ventricular blocks too. And then heart failure. This others, they can happen. Pericarditis, it's an inflammation around the pericardial sac. Not an infection, it's itis, it's inflammation. Dressler syndrome, it's a hypersensitivity response, so you had some cells die, some of your heart died, and your heart is extra sensitive at this point in time. Cardiogenic shock, so it's a marked decrease in your left ventricle. And with cardiogenic shock, if we don't treat them aggressively, they're more apt to pass away from us. Infarct extension. I think of the infarct extension kind of like you have one bad apple, and you know, if you put a bad apple in a bag of apples, not that you would do it on purpose, but you know how it spreads to the other ones. Well, think of that with your infarct extension. Okay, you have your infarct in your ventricle, and it spreads. So you have dead cells. The dead cells um, do give off bacteria, and the bacteria goes to the next cell, to the next cell, to the next cell. Okay, and structural defects. So aneurysm, septal rupture, papillary myocardial rupture. Okay, these usually happen like the first week after post-op MI. That's why we do an echo after every MI. If you had a STEMI or non-STEMI, we're going to do an echo the next day to roll out A, we're going to see what your ejection fraction is, and B, if there is any structural defects, so that we can make sure that you are properly fixed before you leave. Because if we didn't do that, you know, MIs, a STEMI, you come in with a STEMI and say it's the Widowmaker, right? We talked about the Widowmaker. Say it's the Widowmaker. You're out of the hospital within 48 hours. Okay, it's kind of like no rest and relaxation in the hospital anymore. We kick you to the curb. Okay, diagnostics, EKG. Simple enough, right? Somebody comes into the hospital, they're complaining about chest pain. The first thing we're going to do is load them up to an EKG. We're also going to do labs, CK, CKMB, troponin, myoglobin, CBC, ABGs. If they're not awake and alert and oriented, we might do some ABGs to see if there's something else going on there. Echocardiogram, and like I said, we usually do that 24 hours after they've had an MI. Nuclear scans are not preferred, because the last thing we want to do is lay you flat on a table and take pictures and throw radioactive dye into you when you're having a STEMI. And then, of course, cardioangiography, where we can go in and look at the vessels. Okay, so immediate treatment goals: relieve the chest pain. Okay, and it's not because pain. You know, everybody thinks that, well, let me just tell you, whenever you're talking about treatment of an individual, pain is not the number one thing. Okay? Pain is only number one whenever you're talking about a hospice patient or somebody on comfort care. Okay? That is when pain is number one. When we say relieve chest pain, the reason we're relieving the chest pain is the chest pain is indicative of myocardial damage. Okay, if we're able to relieve the chest pain, that means that there's oxygen getting down to those vessels, to those cells. So it's not so much the pain, it's why the pain is happening. Does that make sense? So like if somebody comes in, say in a car wreck, and of course they're in pain, we're going to treat them first. We're going to make sure everything's okay before we give them pain medicine, right? Because we want to make sure, because our number one is to make sure they have an airway, they're breathing, they have circulation, the ABCs. When somebody's having an MI, okay, but we're not going to give pain medicine because that's not going to fix them. When we look at chest pain with an MI, we're helping that patient decrease the infarct. Got it? Okay, so by relieving the chest pain, we can also reduce the extent of myocardial damage. We can maintain cardiovascular stability, okay, decrease cardiac workload. These folks aren't getting up. If they're having a STEMI and they gotta pee, they're gonna pee in a bedpan or in a gosh, I can't think, a bottle. I can't even think what it's called. Urinal, sorry. And we're gonna try to prevent any kind of complications from this MI. So how are we going to do it? Good old Mona. Who knew that we would be using Mona all these years for something other than artwork? Okay, so the immediate treatment's morphine. And you're probably going, Becky, morphine, really? Well, guess what? Morphine is actually a vasodilator. Doesn't it make a little sense? If you give a patient morphine, you have to be careful of their blood pressure because it can tank them. Well, morphine is a good vasodilator. Not only that, it calms the patient down a little bit, and if it calms the patient down just a little bit, it decreases the workload of the heart. Decreasing the workload of the heart decreases the oxygen demand to the muscle. So it's a win-win situation. Oxygen, although oxygen is getting away, what I understand is some facilities aren't giving oxygen for immediate treatment. Their thought is, research shows that the oxygen doesn't really help. I haven't seen research where it says it hurts either. Kind of reminds me of just putting some extra oxygen on those hemoglobin molecules as it's going through. Kind of like, if those have been through OB, if a baby's desatting, you give the mom oxygen and the mom can pass the oxygen to the babies. Well, to me, this is about the same thing. Nitroglycerin, very good vasodilator. Okay, so remember we have to worry about our blood pressures. So we would do the 3, 5 minutes apart times 3. In between, we're going to watch the blood pressure. If that's not helping and they're still at a 10, we just gave them morphine, we gave them nitro, then we're going to open them up and we're going to put a nitro drip on them. Okay, so they have continuous nitro going. And we're going to give them morphine. And one thing that's not on here, if they are in a STEMI situation, we're also going to do heparin. Okay, remember our wonderful heparin protocols? Well, we're going to do heparin because what we want to do is if that's a clot, we want that blood to be able to get through that clot, and we don't want clots to build up on that. So if there's a clot in there, say it's a blood clot that's making the infarct, we don't want that blood clot to continue to build because the blood's just going to sit there, and that's what heparin does. Remember, it doesn't bust the clot. All it does is it prevents coagulation. And of course, our aspirin. Remember the aspirin, we're not going to give them a glass of water and to take the aspirin. They're to chew the aspirin. We want it in their vascular system very fast. So that route is the mouth. Okay, medical management, beta blockers. What do you think? Well, it's because it decreases the workload of the heart. Remember, it decreases afterload. has a little vasodilation action going on. So that would cause the heart not to need as much blood or much oxygen, because we're slowing the heart because it doesn't have to work as hard. You might see patients go home with the beta blockers for about a month after, maybe 2 months after they leave the hospital with an MI. This is because we want to let the heart heal. We don't want it pumping too much. So we want the heart to heal. So we'll send them home with a beta blocker. And as the heart heals, we can, the doctor will take them back off the beta blocker because maybe they really don't need it. But we're giving that heart that little bit more of time. Okay. ACE inhibitors is one of those cool medications that we really don't think about. Everybody, oh, you get an ACE inhibitor because you have hypertension. But ACE inhibitors actually have a mechanism that it helps remodel the heart. So you might see an ACE inhibitor given to a patient, maybe if they have increased damage, so that the ACE can help the heart heal, remodel the cells, the flow, so that when I say flow, I want to talking about the cell flow. Not really telling you the way I'm thinking, so that other cells can do the work of what the dead cells did. Does that make sense? That sounds a little bit more intelligent. Anyway, also, things to note, ACE inhibitors are good for prophylactic reasons. If you are a diabetic, in small doses, ACE inhibitors like buffers the kidneys, helps the kidneys out a little bit. Think about where your ACE inhibitors are working. They're working down in your kidneys. So they can buffer the kidneys a little bit. Now, when patients are in the hospital or even outpatient, we watch their creatinine because it is known that, yeah, a little bit's great, but eventually the kidneys can take a hit from the ACE inhibitors. So we keep an eye on their creatinine. If their creatinine starts creeping up, then we'll change them to possibly another medication. One really cool Jeopardy question for ACE inhibitors is they're finding, that wonderful cough that you have, some patients have, it's a dry, hacky cough because of ACE inhibitors, the ACE cough. Well, what happens with ACE inhibitors with some people is it decreases the threshold of a cough, right? Well, they're finding that patients that have aspiration pneumonia, if they give them the ACE inhibitor, because it decreases the threshold of the cough, it helps them cough up the food. So it kind of hits that spot where it will make them cough so that they don't get the aspiration pneumonia. Does that make sense? So the food actually goes where it needs to go. It doesn't go into the lungs. But it's still a little bit of a research thing. But, if you're ever on Jeopardy and they ask that, you heard it here. Okay, anticoagulants make sense. We don't want anybody, they're going to be in bed for a little bit, so we don't want them to coagulate and get a DVT because they had an MI. So what we're going to do is give them anticoagulants. Of course, if they're going down to the cath lab, they get heparin, but we will not give them Lovenox. Okay, antiplatelet aggregates. Talked a little bit about this earlier. Antiplatelets, so they're going to get aspirin, 81 milligrams, and they're going to get a Plavix. Because if we have to go in there and stent, remember the Plavix helps for the platelets not to aggregate against that stent. Okay, antidysrhythmics, if they need it. We're just not going to throw amiodarone at them. But if they do need antidysrhythmics, that's what we're going to give them. Vasopressors, if their blood pressure is low, we can give them vasopressors. If you have low blood pressure and your MAP, you remember we talked about the MAP, and your MAP's low, that means your kidneys are not perfusing. If your kidney's not perfusing, and then all the toxic excrements, let's say, will reach the body and it can start doing damage. So we want to make sure that the kidneys can perfuse. And thrombolytics. If we're not able to get them to the cath lab, we talked about the thrombolytics before, like TPA, we'll throw them some thrombolytics if we have to. And then wrap them up in bubble wrap because we don't do IMs or anything after they had a thrombolytic. Okay, now at the end of this, I'm going to give you some videos, 2 videos to watch. I'm going to give you a video of an intra aortic balloon pump. Listen, if you're tired, don't watch this video. This Cal Shipley, he's a great guy, I'm sure, and he's a wonderful doctor, explains everything really well. Really impressed with these videos that he puts out, but he really should like tape himself reading bedtime stories to children because he will put you to sleep. I mean, balloon pumps are interesting, don't get me wrong, but dude can really put you to sleep. So please watch it when you're awake so you can, digest the information. Okay, but we use balloon pumps when the workload of the heart, especially the left ventricle, is damaged, and it basically does the work of the left ventricle. It's really kind of cool, and we do use it down in an ICU unit. And sometimes somebody goes to cardiac cath and they're not doing, like they have really bad, um, let's just say they need a cabbage quickly. We'll put them on a balloon and ship them to where they need to go so that so they will actually make it to where they need to go. I hit something, so let me just tell you about the LVAD, left ventricular assisted device. I'm going to throw a video up there on that also. A lot of times we think of heart failure patients, old, decrepit, right, on their deathbed, but LVAD is a real game changer. I'm not going to change the slides because that's just, ugh. Anyway, it's a game changer. So the younger people, 30s, 40s, 20s, that are in heart failure, they can actually live with this device for several years until they can get a heart transplant, or maybe they don't want a heart transplant. Maybe they're scared, it's too much, they don't want to be on anti-rejection medications all their life, then they can use that too. But I'm going to put it up on Blackboard. Please watch it. They're both very interesting. Okay, gives you a little bit of perspective on the technology that we have out there. And this is just the tip of the iceberg too, guys. Okay, now we're on this slide. MI management. Let's see, maybe preparing for immediate PCR. The goal is to get them into the cath lab by 60 minutes from when it is, I mean, really, it would be great if we can get them in by 30 minutes. Cath lab and staff have to be within 30 minutes of the hospital. Now, what used to be is that EMTs would bring, and paramedicine would bring the patients into the hospital. We would say, oh, look, they're having a STEMI. And from that point, then we would call the cath lab. Well, it's gotten a little bit better. And a lot of facilities are having their paramedicine, the EMTs, call ahead saying, hey, this guy's having a STEMI. At that point, they round up their cath lab staff to be ready for when that patient comes in. So they streamlined it, and they've had really good results because of it. Okay. Let's face it, when you have an MI, you're going to have a low fat, low cholesterol, low sodium, no taste diet. Okay. We'll have Mrs. Dash. They're not allowed to have salt. They'll have Mrs. Dash. And a Good Samaritan, I can't believe I'm saying this, a Good Samaritan, we have like generic Mrs. Dash, but for some reason St. Mary's has real Mrs. Dash. And believe it or not, the patients notice. I don't think I would notice, but I was told several times by the patient. Okay, no caffeine, no nicotine. In fact, a couple of our cardiologists will not give nicotine patches to our patients that just had an MI. I know our cardiovascular surgeon, Dr. Wynn, would never allow a nicotine patch. No. Continuous telemetry monitoring, they have to be on tele all the time. Okay, limited to activity progressing slowly. So, we're not going to get them up and walking 26.4 miles, but we are going to get them up and walking. Okay, remember when we were talking about heparin drips, we found out that laying in bed too long causes constipation, bed sores, gastric juices are flowing too much, and they're kind of cause stress ulcers. So we want to get them up and walking, okay? And emotional support. A lot of times these people almost died. It's a reality check. Some people it's a reality check. Some people it's just another day in life, but it's a reality check, okay? So we have to support them the best way we can. Listen to them. Just be there. Okay, hear what they have to say. Cardiac rehabilitation. Now, this goes with our cabbages and with our MIs. Oh, let me just say one thing. With our non-STEMIs, we're not rushing them into our cath lab. We kind of take them in at our pace. Okay, it's not a rush like it's immediate they have to be in there, but we do get them in the cath lab and see where their narrowings are, their arteries. So cardiac rehab with the cabbages and with the MIs, we get them to know those that staff. So cardiac rehab, and you'll see them when you're in clinical. They're the ones in was it Burgundy now? In the morning, they're walking their patients around with a. They'll have a they have a pulse. They have a SpO2 portable that lets them look at the pulse and the SpO2 as they are walking the patient around. Okay, they usually walk them around twice a day. It's really important to get them used to those people in the hospital. We don't want them to go home and say, oh, I had a heart attack. I have to sit in my chair and not do anything because I'm going to die in any minute. No, we need to get them up and moving and get that heart strengthened. Okay, so we're going to get them with that staff before they even leave. And that way they can come to cardiac rehab. It's in the hospital. They have a little gym and they go 3 times a week. They're usually the morning guys. I would say guys and girls. So it's a morning group that's usually cardiac and pulmonary is in the afternoon. But they come in and they do the exercise and they'll sit there and do they'll take their blood pressure and their pulse and their oxygen before, and then they'll exercise, and then they'll take them after, and they're just being monitored. Now, we want them to get in the habit of doing exercise. We want them to get used to seeing those faces because, there's a trust that started building while they're in the hospital. And then they get to know them when they're in the rehab, and guess what? They don't want to let those staff down. They start to become friends, and if you start becoming friends, you don't want that friend to be let down. So you're going to make sure you're going to make it to the hospital and do your cardiac rehab. Okay, we want them to have that bonding relationship. They progress them through the phases, so they'll get them started, kind of easy, and then they'll work them into a regular exercise routine. And the cardiac rehab provides evaluation, exercise, risk factor, modification. They're there for our cardiac patients, okay? And this is the end. It's better to come here on a Friday. Nobody's bothering me. Okay, I hope you guys enjoyed it. Don't forget to watch those other videos, and hopefully I can upload this. Thank you.